Hey there, welcome. We're doing another Wise Women educational series here in my little Facebook land. I'm happy to host this space for midwives and midwifery students as a way to further education, increase the conversation, and just build community. It's so important in our midwifery lives to feel like we belong to a group because there's so much in American healthcare system that is making us feel like we don't belong. So I'm really excited to be able to host this space and create the dialogue, create the community. So welcome. If you're joining us, go ahead and post where in the world you're tuning in from. And I'm really excited to see who's here, who's joining us today. Again, this is the third in an educational series. And it is a way to start the conversation nationally and internationally around blending safe and sacred, the art and science in midwifery. So this is specifically for midwives or midwifery students. So hey to all my mama friends, this might not interest you, but certainly you're welcome to tune in if you want to. And for those of you who are midwives, go ahead and say where in the world you're tuning in from. And specifically, today's workshop is around recognizing fetal distress. So if you could, if you have any questions specifically about fetal distress, recognizing fetal distress, or how to treat, we're going to go into that pretty specifically. But if you have questions, definitely go ahead and make a note so that I can pay attention and hopefully answer those. So we're seeing some people join us. Welcome. I really am excited to host this today. It looks like, see, I'm old, so I have to put my glasses on. It looks like Kelly's joining us from Florida. Hey, hey. And Melissa's joining us from Washington. And we've got Aloha from Hawaii. Kaliko, hello, how are you? I'm so happy to see everyone today. It's really exciting to bring community together from around the country and around the globe. So we're going to get started in just a couple minutes, give some more time for people to join. Again, if you're just joining us, go ahead and post where you're tuning in from, where you practice midwifery in the world. And if you have any questions about the topic today, recognizing fetal distress, feel free to add that to the comments below, and that way I can hopefully answer those questions today. So hey to everyone joining right now, really happy to see you, and make sure and say hi and tell us where you're tuning in from, and also if you have any questions that you'd really like to have covered today, go ahead and post that. So it looks like we've got Chelsea's tuning in from Nashville, Tennessee. Brandy's here from Austin, Texas. Savannah's tuning in from Tecate, Mexico. Lovely, glad you're here. Susan, hi, good to see you. Bethany, yay. Yeah, we're gonna have a good crew today. And it's gonna be really fun to see everyone. And okay, I'm gonna try to do it. Ahendalia, I think I got it right. I'm sorry, I'm so bad with names. From Israel, hey. Alyssa from Los Angeles. We've got Dover, Delaware, Chattanooga, Tennessee. It's so fun to see everyone, and I'm really happy that you all can join me today for the third in the series of the Wise Women Educational Series. And so this is a national presentation. It is free. I do it every month. And I love to have midwives, students, anyone in the birthing world tune in for different topics. Also, I'm going to put a call at the end for anyone that has a specific topic they'd like me to cover in one of these series. I certainly have some ideas, but I'd love to hear real requests for folks what they'd like to see covered. So today's topic is recognizing fetal distress, and I'm going to do some conversation, some talk about that. I have a few slides that I'm hopefully going to make the whole interface work to define a few things. And then we're also, hopefully someone or several of you on the call have a case study that you'd like to go in with asking questions, and I have one or two I'd like to present as well. I feel like that's one of the best ways to learn in midwifery, is to really have the opportunity to put the clinical information in the parts of your brain that will then access it again. And so sequential learning in case studies is one of the best ways to learn. So we've got a good number of us here today. Again, thanks for joining me. It's my honor and privilege to be a national educator in midwifery. And I invite you to tell us where in the world you're tuning in from. And if you have any questions, go ahead and post those too as we go. Celeste, I see, from Michigan. You've moved places a couple of times since I met you last. That's exciting. And again, I'm just really honored and really grateful. So it's just afternoon. I'm going to go ahead and launch into our topic of the day. It looks like we've got Ruth tuning in from Atlanta, Georgia, and Jessica from Medford, and Kristen from Medford. Hey girls, how are you? I'm so happy to hear from you. Alrighty, so the topic of the day is fetal distress. And I really, I'm so glad to present this and so glad to have this conversation, because it is such a huge topic, and it is also so vitally important to the safe practice of midwifery. So I've been teaching workshops around the country for the last couple of years, really honored and privileged to share midwifery knowledge with midwives all around the country. And I've been getting some feedback that is kind of universal. And so there's some real myths out there in terms of what is normal in the fetal heart rate, what is abnormal, and the actions that we should take. So I'm really happy to clear up some of the myths and really focus in on what is statistically and in evidence, clinical evidence, to be the best practice. So first I want to say my information today comes almost exclusively from perinatology.com. In my perspective, perinatologists are really the highest expert in the land when it comes to in utero fetal health. Obstetricians are trained in basically surgery, getting babies out, but perinatologists are the real expert in how the baby's doing on the inside. And that is actually who OBs refer to, and many midwives around the country are also referring to perinatologists when they have complications. So they're really the highest expert in maternal child health, maternal fetal medicine, and so that's a good place to go to start when we are having questions around fetal well-being. So again, welcome to those who are just joining. I'm just going to quickly say hi and see where everyone's joining in from. If you just are, go ahead and say where in the world you're tuning in from. Hey Jackie, I see you. I know you're from Texas. It looks like Jana's tuning in here from Oxnard, California. Valerie from Waynesboro, Pennsylvania. That's exciting. Paige, I know you're in Atlanta. That's so great. Sherry tuning in from San Francisco. Cindy from Woodstock, Georgia. So exciting. So there's just a good collection of folks here. So happy to see you. Yeah, Lahaina, Hawaii, Leilani, I miss you. It's good to see you all here. Alrighty, so the topic of today is recognizing fetal distress. Brittany from Texas, hey, glad you're with us. And just want to encourage you, if you're just joining, to post where you're coming from. Also, post any questions you might have around the topic of fetal distress today. And like I said, when I got started, Angela, when I got started in teaching these workshops around the country, I kind of assumed that the information I had was standard and it's in fact not. And so that's why I feel really called to share this. There's a lot of myths around fetal distress. There's a lot of fetal distress information or fetal monitoring protocols that are still being used around the country with midwives that are really 5 to sometimes 20 years outdated. We have a constantly evolving science around how to evaluate fetal surveillance testing, and so I'm really happy to share that with all of you today. Let's see. Let's go ahead and jump in. I have a few more people joining us here. I want to say it right. Michael, I guess, MYKL, from northern Minnesota, and that's really fun. And, I saw Angela there from Los Angeles. So we've got a nice big group today. Alrighty. So let's do some definitions first, because in order to speak about what we're listening to, what we're seeing, what we're going to do about it, we should have some common definitions. So I'm going to try to make this flip screen work. Definitely say in the comments if it doesn't. Let's see. So let's do some definitions first. Okay, so hopefully everyone will see the shift here. Okay, so what we're going to define first is baseline. So determining a fetal baseline is the most important first step, because without baseline, we don't actually know what we're seeing. I hope this is working. I hope you don't have to turn your heads to read this, but I want to be able to share the whole slide with you. So the fetal heart rate baseline is defined as the most common number with rounded to a 5-beat increment over a 10-minute segment. So just to define that a little further, the minimum baseline duration must be at least 2 minutes, and it needs to be longer than 2 minutes if the baseline is indeterminate. Additionally, the fetal heart rate beat to beat range can't be more than 25 beats per minute. Otherwise, it's called marked variability, and that makes the baseline indeterminate. So let's talk about that. Let's talk about what that looks like in a clinical setting. So the most simple and sometimes shocking change of this information brings to midwives in out-of-hospital practice is that it is impossible to determine baseline if you listen for less than 2 minutes. And frequently we need to listen for 10 minutes in order to truly determine baseline. And so that can be shocking. So let's have a wide open shock face if that's new information for you. And I see it quite a lot in the workshops that I teach. A lot of midwives are being trained to listen for just a few minutes, or sometimes even just for 30 seconds after a contraction. Certainly there is value in that timing. We're going to talk about the timing of listening, but that does not actually determine baseline. Also, you can't listen for a number of 30-second increments and add them together or average them together to determine baseline. That is also not how we determine baseline. So the biggest first change that I encourage out-of-hospital midwives to do is get used to listening for longer periods of time and preparing your clients to understand that you need to listen to their baby for a longer amount of time, so that you can accurately determine baseline. So before we go any further, I just want to say it can be, it is incredibly challenging to do appropriate fetal heart rate monitoring out of the hospital. And for those of you that are continuing your education and working hard to understand this topic, I just really want to say, what you're doing is really high-level midwifery. A lot of people don't understand really the degree of technicalities or technology that we've created in our brain. Those of us who've been midwives for a long time, you can pick out within 5 beats an accurate heart rate from across the room without using a watch. You create a strip in your head. You're evaluating moment-to-moment changes of mom, baby, contraction pattern, position. It's a very complex job. that we do out of the hospital. And so I really want to acknowledge that, and I really want to honor that, because it's really huge work. And that being said, there are some tweaks, there are some changes, there's some updated information that can really make your work more effective and obviously safer. So let's see, getting a little questions here. Okay. Yeah, so a 20-minute strip. Bethany's asking about how do you feel about doing a 20-minute strip, and I would say that is the standard of care in the hospital. Is that women who are requesting intermittent monitoring, whether they use a Doppler, whether they use the EFM machine off and on, intermittent monitoring is the baseline is determined over 20 minutes. And that is to make sure that if the baby falls off or mom's very mobile, that they're still going to get that information. And I think that's perfectly appropriate. But with one care provider listening to one mom who she knows throughout pregnancy, and it's actually her sitting there listening, you can determine it in 10 minutes. And sometimes even 2 minutes if we have a baby that's not particularly mobile or variable. Okay, let's look really quickly. Some questions. Valerie's saying she has some questions about the strip. Go ahead and put them up, Valerie. Connie is saying, at home, what can we do to get these longer assessments? I'm going to answer that today, Connie, so stay tuned. And Bethany's saying there's a backup doc here that recognizes this for his midwives. Yeah, absolutely. 20 minutes is the standard. What I'm saying is that it must be 2 minutes. And it sometimes needs to be as much as 10 or even 20 minutes. But the standard of care in the hospital is generally to have 1 or 2 nurses put a mom on an EFM, electronic fetal monitoring machine. And then it creates a digital strip that they can see at the front desk or they can see in the patient's room. And over 20 minutes, with that mom being sometimes left alone, they will come back and read the strip or read it from the desk and determine baseline. And what I'm saying is with a home birth situation or a birth center situation, frequently it is that specific midwife with that high level of education sitting and listening to that specific baby and only that baby for a full 2 to 10 minutes. And she can determine baseline quicker than a nurse who's in and out. Okay, let's see. Yeah, Valerie's asking, do you have a fetal monitor? You have a fetal monitor, but you never carry it to homes. Yeah, Valerie, a fetal monitoring can be incredibly useful skill, technique, either in or out of the hospital. And I think it's an incredible learning tool, but it is sometimes impractical to have it mobile for home births, and I agree. And it's a very expensive piece of equipment. So we don't want to necessarily have a potential damage with that in transit. So yeah, when and how you use it is quite a specific choice, and we'll get into the appropriate use of fetal monitoring a little bit later. Yeah, let's see. Yeah, exactly, Valerie. Okay, so how often should we calibrate baseline after each contraction? So yeah, Angela, this is a good question. We're going to go into real world application in just a minute. Let's go back to a few more definitions. So baseline is the most repeated beat over 2 to 10 minutes, rounded to the nearest 5th beat, without variability being more than 25 beats per minute. So again, if this, what I'm saying, does not make sense to you, I encourage you to sign up for one of my advanced practice fetal monitoring workshops. And those advanced practice fetal monitoring workshops I teach around the country. And I do encourage you to sign up for that. Again, this is faster and more in one little hour than I normally do in my workshop. So if I'm over your head or you're not understanding my definitions, definitely keep exploring. Also, PESI International is an online continuing ed workshop company that offers some really great programs. Now, it is very mainstream, it is very medical, it is very focused in hospital care, but any good midwife could take that and apply it to her own practice, could learn the basic principles and apply them to home birth midwifery. So PESI International, PESI, definitely recommend them. They do have a 8-hour advanced fetal monitoring workshop that I've taken that I think is quite good, and I do recommend anyone else who wants to further study that it can be really, really helpful. Okay, so let's define a few more things here. I'm going to flip the screen. Okay, let's see if that worked. Yes, it did. So bradycardia is when the mean fetal heart rate is less than 110 beats per minute. So a rate of 100 to 119 in the absence of any other non-reassuring patterns is not usually a sign of compromise. So the reason for bradycardia when we have a baby's heart rate who's low can sometimes be because the baby's OP. Sometimes it's actual issues like heart blocks, serious fetal compromise, but sometimes just that baby trying to navigate the pelvis, becoming OP or even transverse, can sometimes be the reason that we're experiencing that bradycardia. So the biggest piece of information here that's a takeaway for a lot of home birth midwives is that, again, that rate of 100 to 119 is not a reason to transport. That is not usually a sign of compromise. So if we have no other issues that we're looking at, then that would be an appropriate woman to keep at home with continued monitoring. And that is sometimes shocking for people to learn. Okay, let's go into a little bit of visuals. So if this is the contraction pattern here, and this is the baby's fetal heart rate here, we have a baby who started out with moderate or even minimal variability in the 80s and then has dropped to the 60s. This is bradycardia. This is quite concerning. So hopefully we'll have transported back here, before you're seeing this. This is quite concerning and definitely should be transported for. So again, not all bradycardia is benign, but certainly that 100 to 119 beats per minute in the absence of any other complication would be considered a variation of normal that you could continue to monitor at home. Okay, so tachycardia, it means that the mean fetal heart rate is more than 160 beats per minute. So again, in the presence of good variability, tachycardia is not a sign of fetal distress. And this is a really important piece of information. We oftentimes hear peer review or stories of midwives who are transporting with a baby who's hanging out in the 180s, and the hospital generally will draw some labs and will put the mom on the monitors, but they just monitor, and she goes on generally to deliver normally. So that in itself is not a reason for transport as well. The etiology of tachycardia could be maternal fever, fetal hypoxia, fetal anemia, amniitis, fetal tachyarrhythmia, heart failure, drugs, it could be on and on. And so it is tachycardia with other signs or with lack of variability can be quite serious. But again, without abnormal signs and with good variability, that is not in of itself a sign of fetal distress. So here's a strip. So we have a contraction pattern that's almost minimal here, and we have the fetal heart rate. The blue is that normal, 110 to 160 range. And you can see this baby is hanging out way above that. And this strip is actually showing you that this baby may in fact be fine. Maybe mom recently had coffee, maybe there's some other major stimulus going on, but this baby has good variability. We're seeing even accelerations, and so that's a really healthy looking strip. So that's important to know when you're thinking about whether you're transporting or not. Alrighty. So let's talk about baseline fetal heart rate variability, and then we're going to put it all together. So baseline variability is defined as the fluctuations in the heart rate of more than 2 cycles per minute, and no distinction is made between short-term and long-term variability. And it's graded from the peak to the trough. So here, looking at this little mug. So if this is the baby's heart rate jumping along, here is the peak and here is the trough of the variability within the strip. So it's graded in several different ways. So absent variability would mean that this baby is what sometimes is called flatline. This baby has very little amplitude range. And then we have minimal, moderate, and marked. And sometimes moderate is broken out into average and moderate. But essentially, babies who have very minimal variability, they're just having less than 5 beats per minute change. Compared to babies that are in that average range of 6 to 25, and then babies who are of an extreme variability greater than 25 beats per minute. All right, so let's say questions. Hi. Let's answer some questions and see if we're all on the same page. So let's see. Good. No questions as of yet. Let's put it all back together. It's great to see you all joining. And if you just are joining and haven't said yet, go ahead and say where you're joining from. And Allison, hey, I'm going to miss you too. Thanks for that comment. Okay, so let's put them all together. So baseline is the most common beat over 2 to 10 minutes, rounded to the fifth beat. So we never have baselines that are 144. It always gets rounded to 150, 145, or 150 or 155, 160. It's always in the fifth beat. Then we have baseline variability. So from that baseline that's determined with 2 to 10 minutes, we look at the range. And so that peak range to the trough range. And so we're considering that space, that difference between the highest beat that baby got in that listening period and the lowest beat that baby got in the listening period. And the space between those is what determines variability. So while you are listening for the most common beat in determining baseline, you also need to be listening for the range. And that will determine whether this baby has absent, minimal, moderate, or marked variability. Okay? And variability actually has been shown to be one of the highest, most significant predictors of fetal well-being. So it's very important that we're paying attention to variability. Hi, for those of you who are just joining. Anja's from Wisconsin, Connie's calling in from Canada, Kelly from Columbia, Tennessee, and Monica from California. Hi guys, I'm glad you're joining us. Okay, so let's talk a little bit about what previously we've known to be true in midwifery, out-of-hospital midwifery fetal monitoring. Previously, midwives were told and practiced the way that they thought the range was supposed to be 120 to 160. And any baby that was within 120 to 160 was okay. And it was the tachycardic or the bradycardic babies that were struggling. And now we know that that's not actually true. That's a very small part of the story, and it's not enough of the story. So now we know that in fact baseline variability is very important. The fact that the baby is reacting to changes or stimulus in an environment in a beat to beat or we want to see that baby reacting beat to beat, moment to moment. And that's what fetal heart rate variability shows us. The baseline itself only gives us a starting point by which to understand if there are accels or decels. That's the value of the baseline. And in fact, babies who hang out at the 100s during pushing can be perfectly fine. And babies who hang out in the 180s for some time can also be perfectly fine. So range is actually less important than that baby's beat-to-beat variability, that baby's variability. And it's also less important than other co-occurring issues, which we're going to go into in just a minute. So any questions so far? Anyone have comments, questions, something they want to go over? Looks like... Okay, so Celeste, great question. Bradycardia and tachycardia, determining whether the baby's experiencing that compared to an acceleration or a deceleration really is about how long it lasts. So we have a change in baseline when in fact we're listening for that 2 to 10 minutes and the baseline has in fact changed. The most common beat is no longer what it was. So we're going to go into examples here in just a minute. Oh, hey, Carrie. Carrie's on call today in Atlanta. I'm glad to have you joining me. I hope I'm helping you pass the time. Alrighty, so let's define a little bit more here. Let me just show a few more slides. I know it's kind of annoying. I have to flip the screen because I can't flip my computer. Sorry. Okay. Yes, Monica, we're going to go into real world situations. So thanks for asking that. Alrighty, so here's an example. I was talking to you about variability. So these are all baby heart rates. These are separate. They're not on one chart, obviously. So this would be showing, this would be showing no variability right here, where that baby is what we sometimes call flatline. Minimal variability, this baby, its peak to its trough is less than 5 beats per minute. This was called average and moderate. Average and moderate are really the same category, but some hospitals break them out. But essentially, average and moderate variability is the one category together, and that's a fetal heart rate of 6 to 25 beats per minute. And then lastly, market variability is where a baby's range, its bottom trough to its peak, is more than 25 beats per minute. And in fact, looking at that particular one, if the bottom hash mark is 100 and the top is 180, that would be quite extreme to see a baby with that market variability. And sometimes that baby is just going to be a really wild person, but sometimes, especially with co-occurring issues, it can be a real issue of complication. Okay, so now let's look at them broken out. So, you know, we can see here that this one is minimal or absent variability. You see how there's almost no detectable beat-to-beat variability. And in this one, number 2, seeing how that there's now minimal variability changing there. And then here 3, this would be our moderate. This would be the more normal. This is what we expect to see fetal heart rate charts looking like. And then number 4, when we get into market variability, and that baby is kind of looking a little wild on the screen. Alrighty. So I'm going to change slides. We're not going to go into that yet. Sorry. Okay. So let's talk about what we're actually listening for. And right now, I am talking about labor assessment. Certainly, prenatal assessment is important as well, and we're going to cover that really quickly. But right now, what I'm talking about is labor assessment. And so, what are we listening for? Why are we listening? When you ask yourself that question, it almost always comes up that you are looking for the fetal well-being, right? That we're looking to reassure mom, reassure dad, reassure ourselves, check in that that baby's still healthy and low risk and belongs in an out-of-hospital setting. And the only way that that baby can tell us how it's doing is its heart rate in relation to the changes in the uterine environment. And so it has trickled down through the midwifery awareness and consciousness nationwide now that we need to be listening to babies before, during, and after contractions at various times throughout the labor. It's understood now that the baby is having different reactions to different parts of the labor and different parts of each actual contraction. And that's absolutely true. We do need to be listening at different times. And so that's a part of it. But basically what we want to do is we want to get a full picture of how this baby is tolerating labor. So the first thing we need to do is we need to determine baseline. And as I've already stated, the only way we can tell baseline is if we're listening for at least 2 minutes and up to 10 minutes. And like has been noted in the comments, up to 20 minutes if the environment, if the setting in which you're providing the care really requires longer listening. And so during that 2 to 10 minute listen, and I recommend that as soon as you initiate care with a client in labor, so when you get to her house or she checks into the birth center, have already explained to her and the family that your main job is to make sure that she and the baby are both have good well-being. And the only way you can monitor the baby's well-being is by listening to its heart rate for a significant amount of time. So we set up to listen to that baby. Using your handheld Doppler, or if you choose fetal monitoring. And what you're listening for is the most common beat and the peak and the trough, the highest that heart rate goes and the lowest. And that will help you determine that variability, which is very important. Then the next thing that we want to really be understanding is what an acceleration and a deceleration is. So this is how they're defined. An accel and a decel are a change from baseline for 15 seconds and 15 beats. What that looks like in a chart, let me go ahead and pull up an image because this is all very image specific. Okay, so here is the definition of an Excel again. A change in baseline for 15 beats for 15 seconds. And where it happens in relation to the contraction is the meaningful piece that can then label what kind of decel you're looking at. So again, this correlates to midwifery care in knowing what a baseline is and what her client's baseline is throughout labor. It also means that she needs to know when it's happening in relation to contractions, where in labor this mom is, how long it takes to transport from the location that you're doing this birth, and what your receiving facility thinks about you and your care. This will all play into the decision making around which women to keep and which women to send home. So we know that reassuring fetal heart patterns are babies who have good variability, beat to beat and over time, and where there are accelerations present. Non-reassuring fetal heart rate patterns, when their beat to beat variability is lost, or we have late decels, severe bradycardia, or the presence of any decel with rebounds and little to no variability. So there are 4 basic types of decels. There's early, which is associated with head compression. There's variable, which is associated with cord compression. There's late, which is associated with placental compromise or a compromised baby. And then there's the sinusoidal, which is quite of an ominous, repeating pattern that it usually spells loss of consciousness and or severe fetal anemia. And hopefully none of you ever hears a sinusoidal pattern because it's quite scary. Okay, so here's the nurse correlation. The nurses call it veal chop, and they relate variables to cord compression, early to head compression. Accelerations are okay, and late decelerations are placental insufficient. This is a really useful and helpful little chart if you're not used to determining what variability is. So let's talk a little bit about these different variables. So if we're looking at this contraction pattern here, we have a contraction here, and then we have the fetal heart rate here. And so how we define a decel is we have the onset, so we have baseline grooving along here. Sorry. We have baseline grooving along here, and then we have the onset of our decel. We have the nadir of our decel, the lowest point, and then we have the recovery when we've come back to baseline. And down here in the contraction, we have the start of a contraction, we have the peak of a contraction, and then we have when the contraction ends. And so where the nadir goes on the contraction is what determines what type of decel this is. So early decels happen when the nadir starts or the nadir lands before the peak, right? Late is when the nadir lands after the peak. And then variables mean that either of these could happen in random occurrence not related to the contraction patterns themselves. That's what variables are. And so again, here's another example of an early decel. If the nadir is here, it's starting before the contraction pattern there. If the nadir is here, it's happening right at or before the contraction pattern. That would all be called early decels. Okay, now let's look at this one. Late decels. So this is when we have this decel right here is happening, the nadir of it is happening after the decel. So after that peak is where that decel has started. Same thing with this one on this side. Here's the decel, and the nadir is after the peak of this contraction here, right? And then, of course, this would be considered severe variable decel here. This is more mild, right? And they're both decels. They're happening for 15 seconds, 15 beats below baseline, but this one is obviously quite severe. And so it's because the nadir, or the lowest point of this, is at or after, and then this one starts randomly, right? So it has no correlation, and we need to see a bigger strip to really understand what we're looking at here. But essentially, in this evaluation, these are variable D cells. So here's it all kind of put together. I'm going to zoom in and then pull out. So this would be called a reassuring pattern. You see we have no contractions here. We have a baby with beat-to-beat variability, a normal baseline, and then we have this little acceleration right there. 15 beats for 15 seconds. And again, this is too small to really tell that, but we're going to trust that that's the organization. And this is a nice, healthy pattern. So now we're going to look at these late D cells here. So this baby has lost variability. You can see by the baby's heart rate in red is not scraggly. It's just flat. And these D cells, these dips below baseline, are coming after the peak of a contraction every time. So those are late D cells with a loss of variability, and that's quite scary. We should definitely be transporting for that. Hopefully before it gets to that situation. And then here we have variable D cells. This one kind of starts before the peak of the contraction. This one is sort of after. It's not a consistent pattern. Also, variables typically look like V's or W's. We don't see that because we're not generally doing fetal heart rate monitoring, but that's one way to see the difference there as well. And then these are some severe variable D cells where we can see this one is kind of at, this one's at, this one's actually before. And so this baby is probably tied up in its cord because variables are related to cord issues. Okay. So a sinusoidal pattern is a regular amplitude and frequency, and it is excluded in the definition of variability. Sinusoidal has a smooth, undulating pattern of at least 10 minutes with a fixed period of 3 to 5 cycles per minute and an amplitude of 5 to 15 beats per minute. So that short-term variability is usually lost, and it is very ominous, and it usually means that death is imminent. So hopefully you're recognizing your patterns and you're transporting appropriately. This is definitely a reason to transport. And it looks kind of like this. So we have a contraction pattern here at the bottom, and we have this baby who is in this a wave-like pattern called a sinusoidal pattern, and we would definitely want to transport with that. And so this one, it's opposite. The contraction is above and the baby's heart rate is below, and we see the same kind of wave-like pattern. Alrighty, so now let's look at some examples to kind of drive home what we're seeing. So this baby is not sinusoidal because it's not a repeated pattern. You can see drops over here, but it is having some interesting wave-like patterns there. And I would transport for this. So if you heard a wave-like pattern, don't hesitate to go in. But essentially, here are these contractions, right? And here's definitely a D cell here. This could also be one. And essentially, what this looks like is looks like lates to me. At the peak, everyone here is corresponding with the contraction. You can see here, everyone is corresponding to the contraction. So that would be a reason to go in. Let's see, let's take a look here at this one. This one, the nadir is corresponding with the peak pretty consistently. And again, I would call these lates as well. And that could be early. You might need a longer chart to really be able to tell. But definitely a reason to keep monitoring and potentially even potentially transport. Okay, so let's just really zoom in on this for a second because I want to show the other major thing that I'm seeing come out of my trainings around the country. And that is the idea that if the baby's between 120 and 160, then the baby is fine. And I can't stress enough how not fine that is, how not true that is. Here's a perfect example. This baby's baseline, the most repeated beat is about 150. So this baby's baseline is 150. And the lowest point this baby gets to is a 110, or even, it might even be more like 115 is the lowest point. Yeah, about 115. And yet, that's a normal range, and yet this baby is not normal, right? So it's really about determining baseline and then seeing how the heart rate changes in relation to the uterine environment. So this baby is having a D cell of 15 seconds, and it's actually more like 25 for 15 beats. And this one's actually more like 30 beats. But this baby's still in the normal range. But this baby's actually experiencing decels that need to be dealt with. So that's a perfect example of how we really need to understand that we need to change our awareness of fetal heart rate assessment. Okay, let's take a look at this one. So we have a contraction pattern at the bottom here. We have a baby's heart rate up here. Can you determine baseline with this one? No, you cannot. And why is that? Because the peak, the highest point, to the lowest point is more than 25 beats per minute. This baby is experiencing marked variability, which then makes the baseline impossible to determine out of the hospital. And this baby might need to be listened to for an hour on the strip to be able to determine baseline. So this kind of situation, when you're paying attention to determining baseline, you want to listen for the peak and the trough so that you can tell how much this baby, how extreme this baby's variability is to help you understand if you really are accurately determining baseline. Okay, so this mom's not really in labor, and what we see here are some nice accelerations. So again, this would be a really healthy strip. We like that a lot. Okay, let's take a look at this one here. So we have some contraction pattern at the bottom. We have these contractions that are pretty regular. They look like induction contractions, but there they are. And then we have a baseline, which can be determined because the beat-to-beat variability is here. It looks like about 10. And so the most repeated beat is about 120, I would say, 120 or so, maybe 125, but 120 looks like the most common beat per minute. And so 15 beats below that would be about 105. So a decel would be 105 or below, and this baby is hanging out down here in the 70s or so, so definitely experiencing decels. And what we're seeing here is what is called rebounds or overshooting. After the baby's coming up out of the decel, it's going above baseline significantly. These are not accels. They're called rebounds or the baby overshooting. And that can definitely be a sign of imminent challenge. That baby's losing reserves. So when we lose variability or the range, the amplitude, the range goes down, and or we start to see these shoulders or these overshoots, rebound accelerations they're called, that baby is definitely losing reserves, and this would be a reason to transport. Okay, so quick look at a couple more here. These ones, the nadir is after this contraction, after the peak of this one, before the peak of this one, not related to a contraction at all with this one, and after this one. So this is variable because there's no pattern to the decels. So this baby, again, probably is being wrapped up in its cord. Don't hesitate to do some fetal stim. It can be a really great way to assess fetal health when you have questions about fetal well-being in utero, and we're going to go into that a little bit later. It's the same as having a mom drink orange juice or something when she's getting her NST. It's exactly the same. Scalp stim is the same kind of stimulation. Sugar stimulation, glucose stimulation versus actual digital stimulation. It's going to do the same thing. We're going to see if the baby is reacting to his environment. And you can't fake that. The baby either reacts or it doesn't. And that's why it's such a helpful assessment. Okay, so in real life, let's talk about this really quickly. You got to be able to create a strip in your head. We have a real challenge with students. Students listening, we need to encourage them to listen, but at the same time, do they know what they're listening for, and how are they reporting back to you, and how are you making sure that's happening? We have a challenge with technology. How many of you ever get your Doppler serviced? Are you sure that what you're hearing is actually accurate? And then, of course, we aren't listening long term. We're only listening to each beat being amplified. And then we have the cost of technology if we wanted to get something more thorough. And then we also have the question of how frequently does baseline change. Okay. So it's a lot to take in. I know I like to do these in longer segments. So if this is appealing to you and you'd like to dig a little deeper, definitely come take a workshop with me. I'm going to go ahead and read a few questions, see if we can get caught up in that. Okay, let's see. Anja is saying, is there some chart or something to recreate this with a handheld Doppler? Yes, it's called the AAT, the Accelerated Auscultation Test. But I have to say, I think it's wildly inaccurate and hardly supportive in our litigious liability. I don't think you could pull out a handwritten chart in a court case and say, I'm protected because I did assess this. I'm not sure that would stand up. And so if we don't have access to ordering NSTs, or we don't have access to creating the strip in your head, like I'm talking about it, like if you're brand new and still not skilled at that, then the AAT does have some value, but it's very hard to do. Actually, it takes 2 people minimum, and I don't think that it is completely accurate. And I'll go into that in just a second. Brandy asked, do you trust the readout on the handheld Dopplers? So, you know, if you're looking at the numbers that the Doppler is generating once it's averaging, it averages over 2 to 5 minutes. It depends on the brand. And so the readout that you're getting is, or I'm sorry, 2 to 5 beats, it averages it. And if you're counting and it's in alignment with what you're counting, I think you can reasonably trust what you're reading. But only you and your skill should be able to assess the machine, not the other way around, right? So the machine isn't backing you up, you're backing the machine up. Okay, let's see. Bethany says, do you have Dopplers you recommend? Yeah, I mean, I have Dopplers that I like for various different situations. Sometimes we want a Doppler with a high megahertz to be able to listen deep into a very fluffy mama or a mama with a brand new, very small pregnancy. And so the 3 megahertz Dopplers are really designed for that. The 1 megahertz Dopplers is what's standard for labor assessment. And so then the 2 megahertz Doppler is that somewhere in between. So some people always purchase a 2 because it'll give them the most chance of hearing those first trimester babies and appropriately monitoring in labor. But truly, the further you get into this, the more you're going to want to have a specific Doppler for your use. I'm quite a fan of the Huntley. I wish they had a different handheld monitor part. I wish the head was different. It's not super comfortable for midwife or mama. But the machine, the technology is definitely best in class. It's the best in the market. So I'm a fan of Huntley for that reason. And if you do get the 2 or 3 megahertz Doppler, frequently you can hear at 9 or 10 weeks with a Huntley, which is really convenient and nice for some women. I'm a big fan of this Japanese-made Doppler that I can show you in just a minute for labor assessment when we have a question about baseline, because it actually has a graph screen and it will graph what you're listening to, and then you can plug it into your computer and get a printout. And I think that is probably more supportive or protective in the litigious world, is if you did have an actual digital printout. I'm not sure handwritten assessments like the AAT would be acceptable, just because our world is just moving more and more towards the digital age, and unfortunately that's just what's trusted. Do I agree with that? No, not necessarily, but that is the way the world is that we live in. Okay, and then there's all kinds of less expensive Dopplers out there that really do work just fine, as long as you're doing your actual count on your watch and making sure that what you're hearing is being appropriately recorded. Alrighty, so before we move forward, does anyone have any questions that you want me to cover that I haven't already? Any further definitions of what you're listening for, what you've heard, or any other concerns that you want me to cover? Just kind of wait for people to see if they have any questions. I know there's a little delay today. Okay, let's see. Anja says, yeah, the eBay has the Japanese Doppler, and I'll grab that in just a second so you can see it. Okay, I'm going to flip the screen one more time so that you can see the category definitions of assessing fetal heart rate. So we assess baseline, we rule out bradycardia, tachycardia, we determine
the beat to beat or the long-term variability. We determine variability by the peak and the trough. And then we're looking for accels or decels. And we take all of that information, also if there's meconium or, where in labor she is, what she's eaten, how far on pregnant she is, blah, blah, blah. We take all the information that we have around that baby's well-being. And then we assess for one of three categories. And this, apropos charting, this is appropriate charting in out-of-hospital midwifery. So we have category 1, which is normal or a good baby, normal fetal heart rate assessment. We have category 2, which is it's indeterminate, atypical. We don't know what's going on. We can't determine one way or another. And then we have category 3, which is abnormalities are noted and or we have a baby who's going south. And so let me show you the chart that will help you determine that. So let me zoom out so you can see it all the way. So category 1, these normal good labors, it's a good baby. That means that it does have a fetal heart rate range, a baseline between 110 and 160. So the baseline is in that previously understood normal range. It has moderate baseline variability, that 6 to 25 beat range, that amplitude from peak to trough is 6 to 25 beats. It does not have variable decelerations or late decels, which means that earlies are okay, right? And it either has present accelerations and early decelerations or not. But this baby is normal, right? Now going down to category 3, the baby either has sinusoidal pattern or absent baseline variability and recurrent lates, bradycardia, or recurrent variable decels. So that baby would definitely need to be transported. And so then we have this middle range, this indeterminate, this category 2. And it means that the baby is not a 1 and not a 2, and you can't induce accelerations with fetal scalp stem, right? So if you're trying to determine which category this baby is, that scalp stem in labor can be one of the most helpful ways to see if you can induce an acceleration with that stimulation. That would bump that baby up here to a category 1, and it's okay to keep taking care of them. Okay, so let's flip, see if we have any other questions. Okay, so Cindy, what's causing that shouldering, that rebound, is that baby is overshooting. That baby is trying really hard to get back to baseline, but can't. And it's a sign of fetal distress linked to placental insufficiency, and it's a real sign that baby really is losing reserves. When it's overshooting like that, it doesn't have the reserves to keep going in labor. Now, we've all seen it, and then the baby comes out 10 minutes later and is fine, before transport could even be considered or initiated. But especially if it's missing beat-to-beat variability, if we're missing that trough range version, then that baby would definitely be a reason to transport. Yeah, so Cindy, the shouldering can happen with any of the decels, right? So early, late, or variable. But it almost never shows up in early. Well, I won't say that back. Sometimes it does. But it's particularly ominous when it's related to variables or lates. Because we know we have cord issue there. With an early decel, we have head compression. The baby's just being squished. And as soon as he stops being squished, his heart rate returns to normal. With variables or lates, what we're dealing with is actual cord compression or placental insufficiency. So we actually have asphyxia there. Whereas with the first one, we don't. We just have a baby who's under stress. So that's why it's not as concerning. I hope that answers your question. Yeah, so now putting it all together, here are some questions we should be answering, putting it all together. How often should we be listening? How long should we listen each time? And where in relation to the contraction should we listen? These are all important questions. So here is the Japanese Doppler. Oh, I'm seeing some people saying it got interrupted or cut out a little bit. Sorry about that. If you post where I left off, I'll try to catch you up. Okay, so here's the Japanese Doppler, and it's like PC897 or something. I can't quite read the top of the Doppler, but I'll go get mine in the other room in just a second, and you guys can see that. And then we have these different electronic fetal monitoring. This is Huntley, and this is another mainstream brand. I can't remember right now. They're both portable. They could be taken to birth centers or home births. Usually it's not necessary as long as you get skilled at creating this chart in your head, but it certainly is, especially as you get more and more experienced, or while you're getting experienced, having more options to see it on paper can really help you get better at what you're hearing. Because it's very complex what midwives are doing. It's very complex putting all these pieces together. Okay. Nope, I'm not going to share my slides. Sorry. They are on here. You're welcome to rewatch this video. It'll go up on my YouTube channel, and it can be shared and slowed down and fast forward and watched as many times as you want. So no, I'm not going to share my slides with this one, but I would love to have you at a workshop. I do teach advanced practice midwifery workshops around the country, and I have one coming up in March in Knoxville, Tennessee. And I have one coming up in Oahu and Maui in May. And then I'm going to be in Boston in June, and a few places in the fall, including South Carolina, I think, and Florida this fall. So I hope to be able to connect with you guys. I have an Oregon workshop as well in April. So I'd love to be able to have some of you in my workshops. We have a really good time. Some of the folks on this call have taken my workshop, and it is very full and complex, but we do have a great time, sisterhood connection and learning together, and it's really fun. So definitely think about taking that. Okay, so let's see. Some questions here. Is it possible to determine the type of decel via Doppler? So Danielle, yes, it is possible to determine the type of decel, but the Doppler doesn't determine it, your brain does. So you have to know the baseline, and you have to then know the variability, and then listen for 2 to 10 minutes or longer in order to understand what you're hearing now in relation to the contractions compared to the baseline you already identified. See, this is really complicated stuff. Anyone who thinks that midwives aren't smart is crazy, because it's really hard. The real question becomes, let me get back to your question here. So yeah, there are many mainstream medical worlds that believe that this is not possible, that home birth midwives cannot actually determine safely fetal well-being. And I would say, I think that happens a lot. I think there's a lot of midwives in practice who are not accurately assessing fetal well-being. Yes. Is it impossible? No, I don't think it's impossible. I think it takes high-level reasoning, high-level perception. I think you have to put a lot of pieces together and understand in a very grand way the big picture. But I think it is definitely possible. Complicated, but possible. Okay, let's see. Yeah. Alrighty. So, yeah, let me go grab that Doppler. And of course, if you have any last questions, please go ahead and post them here. I'd love to answer any questions that you have. We're going to talk quickly about a case study. And then I'd also love any recommendations that anyone has for other topics that you'd like me to cover in the months to come. So I was just at a workshop in Arkansas and have all of my equipment still packed up. So give me a second while I dig out this Doppler, because I think some people would like to order it. Let's see. Alrighty, so I'm back. Let's see. So info on my classes, Connie, AugustineColebrook.com has some info, and then I have a s'mores flyer I'll put up as well in my Facebook page, so you can see it. Alrighty. Okay, so Anja's asking about
concerns about exposure to ultrasound. And certainly, I mean, I think I have the same concerns that everyone else does. You know, we live in this very interesting technological, litigious life that we live in, right? Everyone's suing everyone. Everything's based on technology now. And we have babies who are being exposed to ultrasound, which is really radiation. And yeah, I have some concerns. And so to answer that fully in the context of practicing in this current modern age, I would say I have some bigger concerns about midwives who practice without it because of their ability to go on and not be sued and not lose a baby and not be shunned in their community and not deal with the real repercussions that could happen as a result of not having the full information that this Doppler technology brings us. So while I definitely have concerns about the exposure of babies, some of you have taken my workshop, you've seen my triangle, right? So we have mom, baby, and midwife actually exist on a triangle together. And to have sustainable midwifery practice, we need to hang out in the center of that triangle, advocating for mom, advocating for baby, and advocating for ourselves. We can't go on and serve the next 100 moms that want our care if we aren't still in practice. And so I have some concerns for baby. I have bigger concerns for mom if she loses a baby because I failed to catch fetal distress, and I have some bigger concerns for me. So in that situation, in advocating for the healthy, balanced, sustainable care for all three that come together in birth, I have to recommend the use of ultrasound and Doppler technology. Now, that doesn't mean that some moms shouldn't be able to refuse that. I am absolutely 100% supportive and proud of an informed choice conversation about everything with your clients, offering the option for informed consent right next to informed refusal, and really having a space in your practice for well-researched, informed decision-making on every topic. And so if a mom would refuse care, then refuse that type of care, then it comes back to you thinking, what am I willing to do? How far out on a limb am I willing to go for this client? And that might be an individual decision. It might be a bottom line that you come up with for yourself. For instance, my bottom line is that I can't effectively take care of a fetus when I can't use a Doppler in labor. Throughout pregnancy, no problem. I'll use a fetoscope. I'll not even listen. I think that's her call in pregnancy. But during the stressful experience of labor and delivery, and no matter what you say, it is stressful. It might be a good kind of stress, but it's stressful for mom and baby. And during that course of experience of labor, I can't effectively monitor that baby without being able to listen before, during, and after a contraction for 2 to 10 minutes without mom laying on her back and being silent. And so the fetoscope is just not technology that will provide us with enough information to make these skilled decisions. We do need Doppler for that. So that's my bottom line. You might come up with a different bottom line. And again, I don't think any of us should be in a position of shaming or criticizing midwifery policy and procedure development, but definitely have a bottom line. Definitely develop it. Definitely know what you're going to say no to, what you're going to say yes to, what's okay with you, because you're a part of that triangle too, right? It's not just about mom and baby, it's about midwives. So that's kind of my spiel on that. I hope that answered your question. Okay. Great. Yeah, I hear you, Anja. Thanks for asking that. Rochelle's suggesting we do a breech birth workshop in one of these, and I certainly could do that. It's a little harder when we're not hands-on and can't practice, but there you go. Okay, so here's my little handheld guy here. Let me just show this to you. Here it is. It has two different heads. So this is the basic one that listens to mom with the midwife holding it, but this does come out very easily. It's made to disconnect, and then it has a flat disc one like at the hospital, like this guy right here. It has a flat disc attachment that we plug in and then can use. So let me just show you. It's the PC86A, and you can look for that on Amazon or on eBay.
So this has two different functions here. It has a light function, which I always love when we're in the dark birth rooms. So if you do like this, it'll give you the count, the number count, and then if you change formats, then it'll give you the graph. And so it's a running graph there. And this kind of goes along with real time, and then if it were actually picking that up, you would see the graph of the fetal heart rate. And this will go for approximately 20 minutes. It is time and date stamped. And then it has the plug here that you can interface with your computer. So then it has a program you download so that then you can print off the attachment that you've got. And this is not super high tech, but it at least, when you're having trouble determining baseline, this could be a really helpful addition. And it's about $180, so it's very affordable compared to most Dopplers. And it's very easy to use, and it can really bring some reassurance. So I recommend putting that in your bag as well as your regular Doppler. And then certainly as you become, as you have a bigger practice or more demand, or as you become more experienced, a lot of midwives then end up adding electronic fetal monitors into their practice for doing non-stress tests in office, and also for those rare births where you're having trouble figuring out what you're hearing. So that's how that goes. Alrighty, any last questions, any last topics you'd like to see me present on in this Wise Women educational series? And then lastly, I do want to say that I also run a national consulting firm, Wise Women Consulting. I help practices streamline their policies and procedures, their back office documents, informed consent, patient education documents. I help setting up student programs, and I love to midwife the midwife. So, those of you that are new to practice or are planning to expand your practice or open birth centers, consider my firm Wise Women Consulting to help you with that process. And then lastly, I do lead adventure retreats for women. So if you feel like you'd love to do some adventuring with me, some soul journey work, definitely private message me. I'd love to plug you into that side of my life as well. Alrighty, well, it's been a pleasure today. If any of you have any specific questions or concerns, go ahead and post them. We really did have fun cruising through the assessing fetal heart rate. And if there's any questions or concerns, I'd love to answer them. Otherwise, I'll post this on my YouTube channel for you to share with friends in the midwifery world. And it's been a real pleasure. So thanks to everyone. It was great to see you all. And I look forward to seeing you again. We're going to meet in February again, and I'll post that and invite you all again. So thanks. Bye, ladies. Good to see you all. Thanks again. Have a great day. Oh, look at all the lovely comments. Glad you could be here. Thanks, ladies.